We're really excited to have transplant nephrologist Dr. Alden Doyle and Rich Formica discuss the OPTN Expeditious Task Force. So they're going to share updates on the task force's work to increase the use of all available organs and get each organ to the appropriate patient more efficiently and expedite the process of complex organ allocation. So really excited for the discussion. I think they're hoping for a lot of interaction here, so be thinking of your questions. And I will go ahead and turn it over to Alden and Rich. Thank you.
All right, so, this on? Does everybody hear me? So obviously there's certain things going on within the OPTN right now that take a lot of time. However, there's also work to be done. So what is the work that we're actually doing? If you look at the past 10 years of transplantation, the rate of transplant is rising at a rapid rate, 9 to 13% annualized each year. The rate of organ recovery is actually rising at a more rapid rate. And then we've instituted many new allocation policies, which frankly have resulted in the equity gains that were desired, but they also introduced complexity. So you hear, and when you travel to regional meetings, you hear of nights on call by surgeons and just getting overwhelmed with the number of offers that they'll never see. You hear about logistics that are difficult to organize and to get organs transferred. And most importantly, we track the number of organs that aren't utilized, right? So last year, when you look at kidneys alone, 8,547 kidneys were recovered, but not transplanted. And then the question is, well, what's going on there? Now, certainly not all of those kidneys are transplantable, right? We all know that. That's been shown by Darren Stewart long ago. However, many are, and the question is, you don't meet transplanters who say, hey, I've got a plan for this year. I'm going to do fewer transplants. So you have to ask, what's going wrong with the system that makes those organs not get used? And that's really the things that we wish to do with this task force. And I want to give you just a real example. So this was my Wednesday night, and I was here, which was nice, so at least I wasn't home. And I was texting with our surgeon on call, and she was getting hammered, right? So we were trying to bring in a kidney from far away that was a very young donor. It was an AKI kidney, and we were trying to organize a biopsy that was brought to Yale after a H&E biopsy was done to see if it had cortical necrosis. She was working feverishly on a HOPE Act offer. And then I got this text message, and it was, I'm not going to de-identify it, but a nice 22-year-old gentleman who passed of brain death, significantly outside of the 250 nautical mile circle, and coming to us because it was declined by others for a history of a positive Russell Viper venom. And so those of you from medical school, you're like thinking, okay, I remember that from hematology. What does that mean? That means you might have a lupus anticoagulant. That's what that test means. You might have a lupus anticoagulant. So I used one of the emojis that my kids have taught me to use, and I sent back, why are they declining for this? And the answer came back, which I thought was very insightful. I think time of day is also a big factor. If one center declines in the middle of the night for a silly reason, usually others follow, right? Well, this others follow. This is like, this kidney's coming more than 1,500 miles for us to use it. So on the one hand, I was thinking to myself, this is exactly why I like working with this surgeon. She takes her job seriously. She's working hard at night, et cetera. But then I thought to myself, is this really sustainable in the long run? When you think about what all of our lives are like, you have these young physicians working hard, trying to get things done, but can you really build a whole system on that? Or should the system be modified in a way to enable the physicians and surgeons who take care of these patients and do these transplants to do so in a manner that's both sustainable and efficient? And that really gets to what Alden is going to talk to you about. When we put together this working group, this task force, and by definition it's not called a committee, the goal was to do the work, to figure out how to make the system more efficient so that we can use all the organs that are recovered. So with that, I'm going to turn it over to Alden, who's going to tell you about his committee, and then we'll have an open forum where we'll take just about any question that you'd like to ask.
Thanks, everybody, for coming for an early morning session. I'm excited to be here. So I wanted to introduce, I think I have here slides over here. Wanted to introduce some of the work we've been doing, which is exciting and fast moving. As Rich said, it's a task force, not a committee, and it's really a response to try to get things done more quickly, hence the name. So recent creation, the Expeditious Task Force in 2023, and it's really the goal to increase the number of successful transplants and looking through pillars of reduced discard and non-use and increased efficiency. So, surprise to no one, we're experiencing record growth, and with this comes complexities. So we've had a successful 5 years with donor increases and growth in transplant overall, but it's not keeping up because the demand for successful transplant is outstripping. And as Rich says, there's an unacceptably high rate of non-use and non-utilization that is really hard to explain to donor families and to patients who are waiting on the wait list. This was explored, I think, in part yesterday with a patient experience. These non-use and non-utilization, I'll tell you a little bit why they're different, but is a real opportunity for improvement. Simply by maximally utilizing the organs that are available to us by donors that are identified, we could have a huge increase in transplant and go a long way to meet the need. And everything in healthcare is changing, so transplant's not excluded from that. And so we want to borrow from outside the industry and inside the industry and look at new ways of doing things. Oh, and I forgot to mention, I apologize up front, so we're working with our close partners, HRSA, and so for any of you who've been to the regional meetings, this is largely the same slide deck, but I'm going to do this a little differently because we're not going to have breakout sessions. I just want to, build on the natural CEoT kind of vibe and have open discussion. So we think, and I think you would agree, that organ transplantation is at a critical inflection point. There's lots of changes going on. Hopefully they'll be positive, but it's going to be complicated. So we believe that we have an opportunity to modernize the transplant system, give more patients a second chance at life with gifts to donor and family, and honor that gift. So as I mentioned, our pillars here is really growth, so growth of successful transplants. So I'll talk to you about how we got to our bold aim and why we chose this. And we believe that it's a time to focus more, as we've made gains in equity and allocation, that we need to look now at increasing efficiency and increasing use and utilization of the organs that are available. As we discussed already, and as a focus of this CEoT meeting, there's lots of other technologies coming online. So AI, for example, was talked about. It was a great session yesterday. Have a lot of promise, but that's not exactly now. So as we start to look at that, so we're looking at things that are going to happen now and also for the next steps. As with all of this, we remember that the reason we do this is with patients, and so we're trying to make this a patient-centered approach, and that means to include their voices. I'll talk to you a little bit about that. Include the voices of the donor families and take into consideration their perspectives. It's pretty clear that when you're on a waiting list, and especially if you're aware of how unsafe it is to be on a waiting list in terms of the mortality associated with end-stage organ disease, that they want access to transplant, and they sometimes look at it differently than we might in the field, not always. And so we want to take in consideration what their feelings are and what the feelings of donor families. And so we believe that by having more standardization across the process, more streamlined processes and optimization, that helps meet their needs. And this is really what we're hearing from patients and donor families. So very intentionally, this task force is a little bit different than a committee. It's not a committee. It works with committees. So it reports to the OPTN, and this is allowing for all the vagaries that are happening with the UNOS contract, and there's lots of things that we don't know what's going to happen exactly. But so the task force was designed in order to have broad voices across our ecosystem, right? We are the ecosystem. We are the people that make transplant happen. And very specifically, we look to have donor families and patient representatives on the task force. And we also very intentionally thought through ways in which we could have their voices be heard. So not to have them, like sometimes this happens, congregate in one table and be over here. This is the patient family group or the patient or donor family group. So it thought through ways in which we could make sure they're up to speed, make sure that they understand all the details that are being talked about, and make sure they have a voice. So we very intentionally did that. We're involving community advocates. We're trying to involve voices inside the medical community that have been supportive and voices that have been contrary, because they both have something to add to this process. So very intentionally got folks from across our ecosystem, different kinds of viewpoints to be part of this, including OPO staff and then some current OPTN board and committee members. So we thought that, like other major changes in healthcare, we needed to go beyond incremental. And if the goal is growth and successful growth, we wanted to think about ways in which, under the current system, there's future growth, but under the current system, how bold could we go? What is the way that capture attention and really be a breakthrough change? So we thought this takes new thinking, this takes empowerment of different voices, that takes a look at systems, different ways of doing things, and looking at expertise both within the ecosystem and sometimes outside the ecosystem. Sometimes the barriers are things at the level of the hospital or resources or public policy or reimbursement. So looking at all those things on the table. So after we came up with this, we thought about this a lot. So what is our bold aim? We're primarily focusing on this case, not because it's more important than living donation, but just because it needs more efficiency and it's a time to have this discussion. We're focusing on deceased donors. In no way does this diminish the super important role of living donors, but for our work, it's going to be a deceased donors, and we wanted to make it successful transplant. So what we did was take a look at what the top 25% of programs, and again, it's not just kidneys, although kidneys tend to drive a lot of the numbers because there's a lot more transplants there, but specifically all solid organ transplants. Look at the most successful transplant programs in terms of growth that have also maintained outcomes. What did they do? So they're able to do this under a current environment. Now maybe they have things that are different, or maybe they have extra resources, but current level of donors, current technology, current immunosuppression, current monitoring, all the things we were talking about yesterday, they haven't changed yet. What can they do now with what's available now? And if we push that across, so all the transplant programs in our ecosystem were able to do what the top 25% of programs who did, we could reach 60,000 transplants with the things we have now. We thought about 100,000 by 2030, but this is our immediate goal. So we think this is bold enough. This is bold and not incremental, and this is available to us. This is conceivable and doable with things that we have right now. Now, recognizing that we need to be more efficient, we need to think through allocation, we need to be nimble and look at ways to reduce barriers, but not with any new technology, not yet AI, not yet new undiscovered ex vivo perfusion, et cetera. Stuff that we have right now. So we're looking at all these different things, and in no way done, but we're trying to move quickly and have some things ready to roll out. So our current Expeditious Task Force initiatives are to think through, and I'll talk about this a little bit, the potential rescue pathway test. So one of the things that's caught a lot of attention is our public comment for variance policies, and I think this is somewhat misunderstood, so I want to take a minute to talk about it. In the current bylaws is a mechanism to do variances, and then originally, as it was originally conceived, it wasn't permanent variances to have, which existed once upon a time, and all of you know about. But more small, we're imagining this as it was originally conceived as small ways to test, to pilot change, and then make this iterative with predetermined metrics, and so that by the time we go back to policy, which is a slower process and necessarily involves public comment, that we're informed by data. So that's one of the things that we're trying to do differently that will allow for a much more rapid pace of change and allow for piloting of different ideas. So one of the natural ways to do, areas of focus is in a system right now that has a lot of out-of-sequence allocation. We see this as an imperfect system. So we're not promoting out-of-sequence allocation, but it's not because people are trying to cheat, our belief. It's because people are trying to respond to a system that's not allowing for efficient enough allocation of medically complex donors. So there's workarounds. And in the workaround, it may not always be what we intend. There may be out of sequence, and it may not always be perfectly equitable. But there are things in there that could work. And we know if we look at our European colleagues, they've done things differently with medically complex donors. And so one of the discussions I want to have today is think through how we could do this. So our idea here is to look at current practices, things that may work in one area, DSA, or with one OPO and transplant center collaboration, and pilot them. Have a data dashboard, take a look at a system that's being done now, and see what works. So that if we go to the next step, we try an iterative process, and it seems to work, and we learn from it. By the time we go, as I said, back to policy, it's based on data, and when the public comment period is there, it's based on an actual experiment in our ecosystem. We also want to understand while we're doing that, and we want to understand what's going on, what's driving these things. So we want to conduct studies to better understand non-use and non-utilization. There's a lot of different reasons that organs have non-use and non-utilization, but there are some current themes. One that we'll talk about is as you add cold time, post-cross-clamp, cold ischemia time, no matter the organ, it becomes less usable. There's maybe not exact threshold, maybe there are some. And obviously there's other factors involved, but if you can limit the cold time, get organs to the right recipient with less cold time, they're more likely to be used. And then on top of that, there's best practices for organs that have accumulated more cold time, because some programs have done a good job doing this and have successful outcomes. We also want to look at barriers. And some of these barriers are inside us, so these may be OPTN bylaws and policies that were well-intentioned but no longer serve us. I think the current work of the MOT committee is a good example of this. Like, we didn't anticipate how many multi-organ transplants there might have been 20 years ago, and so it's complicated, and it's something that deserves taking a second look at. So there's lots of things that there may be barriers inside our own system, and there may be barriers outside the system. For example, the one that I like is that the barriers to moving DCD donors into a donor center. Unanticipated hospital policy barriers that we could potentially address. We also want to, like all major change, you have to secure commitments. We've involved others who have done this successfully. Ken Kaiser is a good example, where there's been major healthcare initiatives where they've changed things. Smoking campaign, safety campaign in the VA system, where major changes have happened and it's required securing commitments. So we've gotten the expertise and invited these folks who have this experience in, because we think we're going to have to secure commitments both inside of our ecosystem and outside. We've heard from transplant centers, for example, if I was to grow this much as you're expecting to get to 60,000, I'm going to need more ORs, I'm going to need more staff, I'm going to need more time. I'm going to need to secure the commitment of the C-suite for transplant. So what does that look like? And what's that message nationally, the messaging nationally, and what are the people that we need to get commitments from? And we also understand that we've been, although there's a lot of effort here, we're not always perfect at messaging across our ecosystem. So we're very intentionally thinking through ways to message this to patient groups, to outside groups, to hospital C-suites, to different member organizations within the transplant ecosystem, so that people can understand and have a chance to discuss this, which is what we're doing today, and give us feedback so that it's felt like it's an organic process from within the community. So what I thought I'd do is, in the regional meetings, as I said, you may have seen some of these slides, what they did was some workshops, and what I'm going to do is go through a couple of the things where we're having some key projects, and then I'll stop and I'll try to invite your questions and feedback at each of these spots. And so one of the key things we're looking at is removing barriers. So some of the things we've talked about, this is certainly not exhaustive list, but things that we've come up with in our initial discussions were, we understand that that outcome monitoring makes some programs hesitant to take medically complex donors. Now, if you talk to the folks at SRTR who are on the task force, they would tell you that there's risk adjustment. May not always be rational, but nonetheless, there's a clear feeling that outcome monitoring may slow down certain programs to take on complex donors or to take on new initiatives. So that's true. Also true that if you've undergone a review at your program, and I've had these at some programs I've worked, you get cautious. That may not also be rational, but that's often what happens. And so what are the ways that we could work with NPSC, and we're talking with them next week, to make a moratorium or change the threshold so that programs would feel more emboldened to try to do more growth? That would be one idea. That's removing a barrier, something that we could work on. One of the ways is we could think about we know that certain OPOs have figured out pathways for out-of-sequence allocation. We'll call it a rescue pathway. So what about the UNOS Organ Allocation Center? Maybe we could get them into thinking about how to work with us to do rescue pathway allocation in a setting of a study, a pilot. We could think about, like we did for PHS elevated risk kidneys or organs once upon a time. We know that having a separate consent for certain kinds of organs sometimes is misinterpreted by patients. Like if I have to sign a consent, that's probably not a good kidney for me, for example. So maybe we should abolish the separate consent for KDPI kidneys over 85, as an example. Maybe we should not use KDPI as such. Maybe we should bucket KDPI into sequences of kidneys, A, B, C, D, because there's not really any difference between a 40 and a 45 and a 50 at an individual patient level, and it's adding complexity. Maybe we should have incentives. Maybe like one of the things I like, just as an example, I'm just throwing it out there for consideration, that if you're a patient and you take a medically complex donor, maybe you get some credit. So if that kidney fails early, I'm using kidneys just because I'm a nephrologist, but there's other ways to other organs. So if the kidney fails early, that you get, let's say, 5 points. And then if the kidney lasts for 2 years, you get 5 minus 2, and you get 3 years for a second transplant, or something like that, where you incentivize the patients to take more medically complex organs. What are the ways in which we could grow? We know is when programs have used medically complex organs, largely they're successful. Largely this saves lives. And so how can we figure a system that makes that work? So I want to take a second there and just think about that before we go into rescue pathway protocols. I'm interested in your comments and feedback. What are the ways that we could think about, what are the barriers that we could think about removing inside of our system, inside the bylaws, and outside the system?
Thank you. Sami Al-Asfar, transplant nephrologist from Mayo Clinic, Arizona. You mentioned incentives for programs to take medically complex or organs from medically complex donors. How would we define medically complex donors?
It's an excellent question, the million-dollar question. So we should think about that. So part of our work is to we know that what I'll talk about a little bit later is I think we need to study that. What are the things that actually trigger non-use and non-utilization? And I'll look at, it's an excellent question, 4 different separate studies that all ladder up to that question. But I think you have to have a definition. So we also know that OPOs across the country have come up with their own definitions that work for them. Not that they're exactly right, but in a pilot, you have to have an a priori definition. We could use one of these definitions while we're studying this to better understand that, because I think that's critical.
Hi, Dave Foley, Wisconsin in Madison. Thanks so much for having this session and joining us at the meeting. I think one of the barriers that not a lot of people understand about is the barrier at the operating room. Not every center has an OR available at any given time to do a kidney transplant. So we do about 300 to 350 kidney transplants a year. We accept a lot of kidneys, but the problem is there's other services in our operating room. We can get a liver in at any time, kidney pancreas, less barriers, fewer barriers, but for kidney transplants, you can put them on the pump. We are constantly negotiating to try to get all the 3 or 4 kidneys that we accept into the operating room. So when we receive them at 26 hours of cold time, and it's a KDPI of 93%, there's reluctance there because we're not going to get it in the operating room at 29 or 30 hours. So there are barriers for us to get them into the operating room. So one thing you all could do is mandate an e-transplant room for every transplant center who's involved in the process, because just like the American College of Surgeons, so the American College of Surgeons mandates that every level 1 trauma center has an operating room available 24/7. So if that messaging can get to the transplant centers so that we as surgeons can say, that's our room, we need to get our transplants in, I think that would really help with the utilization, because it is a barrier. And we're getting these organs at longer cold time, and that's probably impact. I just reached out to 5 other transplant centers recently to see how they manage this, and everyone has the same problem. These are transplant centers with level 1 trauma centers. They have orthopedic trauma, And every hospital is stressed with capacity right now. So bed availability, OR availability, I think is one area that could be really a good focus.
Thank you for that. Excellent. I totally agree. And we are very, very aware that in order to grow, a lot of the growth will come from medically complex donors, and they have longer cold times or may have delayed graft function, et cetera, et cetera. And so there has to be messaging and commitment on the part of the hospitals, we believe, in order to make this happen. And if you look at those top 25% of growth centers that we talked about, in one way or another, they've all been able to get their C-suites to commit to things like OR time, exactly as you suggest. So that's an excellent suggestion. Thank you.
But they do scramble, though. They scramble. They don't all have an e-transplant room. We're begging. Surgeons are begging for rooms, even at the very high volume centers, from what I can see.
Yeah, yes, sir. I totally agree with you, and we are, how to do that exactly we're working on. But we think that's the part when I was talking about securing commitments. You have to have commitments outside of the transplant ecosystem per se, because those things have to happen in order to grow.
Yep.
Thank you. Yep.
So Dave, this is, it's sometimes when you start something, unexpected things can happen in a positive way. And without overstating, what's been most rewarding about this project that's been started is Diane's actually been able to engage CMS to begin to talk with us, because I think they realize there's a value here too. Now, where those, if the OPTN is complicated, CMS is beyond complicated. So how far they can go is difficult to predict. But the reality is, I don't remember a time when they've been so willing just to engage, talk, and listen. And what comes from that downstream engagement, you don't know. But your ideas about, if you're going to be a transplant center, what are the commitments the transplant center has to make, then that starts to fit into a narrative to sort of get to where you need to be. So I think that's a great idea.
Yeah, along with what Rich is saying, we went to the CMS meeting recently in Baltimore, and they were so engaged. There's different parts of CMS, but looking at things that are not traditionally funded, like talking about use of ex vivo perfusion and on the cost of that, talking about donor runs that don't yield transplants but are a necessary part of medically complex donors. And so I think it's exciting to see these conversations happen.
I think they were next.
Oh, sorry, go ahead.
Stuart Knackley from Duke. Thank you for the good work you're doing on this task force. And just to add to your suggestion to consider tiered success rates or outcomes measures for increased risk donors. It only makes sense, and a lot of patients could benefit even with an 88% one-year graft survival instead of a 94%. So it makes sense to tier the outcomes to the risk of that recipient. In addition, I would suggest that you look into tiered reimbursement, because the medically complex donor also costs a great deal more for the transplant center to take on, and that is another disincentive to doing these transplants. Yep. One other suggestion is that we have data in our system to identify donors that are going to be futile, and they shouldn't be procured. We'll never get to 100% utilization of procured kidneys, and we probably shouldn't. But if maybe there's a less than 15% chance of a kidney actually being transplanted, it shouldn't be procured in the first place. And we have data that could inform us on that.
All good suggestions. Thank you. Yeah, for their middle one, that was part of the discussion with CMS, and again, there's no decisions, but there was a discussion and an open knowledge and about how about that the growth comes, like most of the growth, at least the way in our 60,000 here, with medically complex donors, and by definition they're complex and they cost more and have longer hospital stays, and so I think those conversations are happening. Thank you. Yeah.
Thank you.
Good morning. Thank you so much for the work you're doing on this task force. I'm Elisa Gordon at Vanderbilt University Medical Center. I'd like to comment on the proposed policy change regarding the removal of the consent process for high KDPI. So I appreciate the intent of that, and it's very much like in recent years, the removal of the high risk, increased risk moniker, okay? And, in terms of being able to just, place the organ and prevent people from pushing back on that, and I get that. My concern is, having done research on patients' decision-making for increased risk organs, high KDP organs, even deceased donor intervention organs. Patients really want to know about the quality of the organs. They want to know what they're getting themselves into. And so I really think it's important that we inform people. We could change the way we label them, whether it's high KDPI, and in fact, that is so confusing to patients. It's so hard for people to wrap their heads around what that means. And so, I would really recommend strongly that whatever policy proposal you'd like to move forward with, that we get patient input on, like, what do you think about this? How would you like to do this better? What would help people feel more comfortable with accepting a high, the equivalent of a high KDPI organ in a way that they can give informed consent for that organ, knowing the potential greater risks involved. So, thank you.
Excellent comment. Yeah, we have very specifically thought this for all the reasons that you're talking about, and are getting a lot of feedback and are doing a lot of outreach with patient and family groups to hear that. And they want, as you suggest, more agency. They want more knowledge. It's complicated, right? But I don't know, KDPI doesn't always capture it. So we could do this and have more transparency and involve them in the decision making, because there's a sense that high KDPI kidneys don't work, and that's not often the case. It's more that they don't have as much tread on the tire. So it may be a 5-year kidney instead of a 10-year kidney, but that's a different discussion. So thank you for that comment.
So, Lisa, I think your point is really good. And putting aside the notion of consent, not consent for high KDPI, but let's just think about the concept there, which is KDPI is sort of taken on a life of its own, right? When we used that or originally developed it, it wasn't meant to sort of give an individual score to an individual kidney. And I think what's happened over time is we've so internalized that use, we're not thinking about how that policy or similar policies can be holding us back, right? So don't just, as you're sitting here and you're thinking of things, don't just think of high KDPI. Think of what other policies made sense when they started, and they've become so part of what we do, we don't even think about, we don't change our frame of reference as to why is this now holding us back. And I think that's really the key behind this notion of just how we want to address high KDPI. But you could probably come up with many other policies that we have that made sense at one time but don't make sense now, and we have to be thinking from a bigger picture.
Thank you, Rich.
Hi, I'm Pooja Singh from Jefferson in Philadelphia, transplant nephrologist. I have some comments. The first being, when you're engaging with MPSC, and we are so focused on our 1-year outcomes and the 90-day graft survival and the conditional 1-year survival, we also have public tier ratings for transplant centers, and transplant centers are very sensitive to these tier ratings 1 to 5. They don't always follow the MPSC flag, but there is a reputation management that transplant centers have to do. The commercial payers look at it, and they determine our Center of Excellence contracts. I think it's key as you engage with MPSC and you engage with CMS, we have to get the commercial payers on the table too. The second being, when we talk about our surgeons, we hear it at our center too, 24/7, lack of staffing, OR availability, transplant dedicated anesthesiologists, staffing, nurses, and whatnot. I think as you engage with CMS, we have to find a way, it makes it into Medicare cost report for the pre-transplant staffing needs of the transplant center to make that surgery happen and have a way to have organ acceptability at a much higher level. I think that'll feed into the C-suite to give those resources, because all healthcare institutions are working with very razor-thin margins right now, and they need that support in order to support transplant centers. And I feel like the KDPI, we have an anchor bias now. It's been around for more than a decade. And we do have issues with getting high KDPI acceptability and consents from the team based on the outcomes for those kidneys and based on the medically complex recipient candidates whom these kidneys may not serve well. So I do think getting rid of it would be a good idea. Thank you.
Yes, thank you. I agree. Thank you for all three of those comments. With the first one, I was encouraged to hear participating in the CMS meeting I was referring to, all the big secondary insurance companies were all present too. So they're at least, I don't know what'll happen, of course, but they're at least part of this discussion. I absolutely agree. Thank you.
Hi. So from the OPO perspective, a couple of thoughts. First of all, I think the concept of getting the organ center out of the equation or removing that mandatory requirement is essential. Your work on rescue pathways and some of the comments you've already made about OPOs have figured out a way to get organs allocated are spot on. The organ center model essentially requires that someone go down the list from 1 to 200,000 or whatever the number is, and that is completely unworkable. The second thing from our perspective is we need real offer filters so that we're not making thousands of offers to people who they have no intention of taking the organ. I sat in a conference recently where people were appalled that a dialysis center could exist that had never referred a patient for transplant, and yet every day we offer 60-year-old DCD kidneys to centers who have never used a 60-year-old DCD kidney. And the argument is always, well, someday we might. Well, apply for a waiver, and then you get a window to do it. But quit clogging up the system with offers that are ineffective. And then I think the last thing in this whole issue is the KDPI. We would celebrate the idea of the KDPI being replaced because it's essentially like the day-old bread rack, and people see a KDPI that's at a certain level and they just start tuning out. And if I had $1 for every kidney over the last few years, that we have heard someone say, if you'd only called me 5 or 6 hours ago, I would have used this kidney or I would have used this organ, I would be in a pretty healthy place.
Thank you for all those comments, and I'm not going to easily get that day-old bread rack notion out of my head, so thank you for that too. I can speak to the offer filters. Working on the Operations and Safety Committee, absolutely offer filters are one piece of this patchwork. As you know, that they made some progress in kidney, and they have more sophisticated filters, and they're already out for public comment and approved as policy is a opt-out system for offer filters. It hasn't been pushed out yet because it was slowed in implementation in order for the other organs to get their offer filters online too, which is starting to happen and should roll out over the spring. And then after that, the originally approved policy for offer filters for kidneys, where although the uptake has gone up and it's been helpful, and there's clear data to show that, we'll present some of this at the ATC meeting pretty soon. There are programs, as you said, who've never taken them that just don't use offer filters the right way, and so the new policy will automatically apply an offer filter around those programs, and they can opt out of that if they choose. But if they don't do anything, then it will filter those organ offers that they weren't going to take.
Becky Day, transplant nurse. Have you guys thought about, when you're looking at 1 year, 3 year, 5 year outcomes, to disseminate those based on the KDPI, so it would give a little bit more latitude for the transplant centers for being a little more risky?
There is that. It already exists, and so if you talk to our SRTR friends who, again, are participating in this too, that they said the risk adjustment's already there and it works. And in fact, the programs that take the largest number of high KDPI organs, they use kidney, I don't want to just focus on kidney, but programs that take the highest number of high KDPI kidneys are less likely to get flagged. So that exists, that system already exists, but like the stock market and other things, it's not always 100% rational.
It's not in a patient-facing form, though. When you have patients go to the SRTR website, it doesn't show which transplant centers are actually riskier, right? So understanding their medical complexities and choosing a transplant center that they would likely get a actual transplant from.
So part of this discussion I had before of having patients have agency and be part of the center of this, the spoke, right, of the wheel, is to allow patients clarity about what the center's behavior is, how they manage their wait list, and what kind of organs they would accept, different wait times and those kinds of things. Again, they can make the best decision, and we understand that not all patients can travel to, depending where they live, there may be not, but at least to have that information so they can make an informed decision. I absolutely agree.
You know, I thought I saw John Snyder earlier this morning, but I believe the SRTR is actually working, I think they call it Task 5, or John, forgive me if I got that wrong. But the idea is to accomplish basically what you've just said. How do you provide information to patients who don't live in the world that we live in, speak the lingo that we speak over the years, that they can actually look at information on the web and say, this program is good for me, this program might not be so good for me. And I think as I'm talking, I'm seeing John walking, which is helpful, thank you. Fix that.
Yeah, thanks, Rich.
Thank you, John.
Yeah, I would just say that the tier evaluations from the get-go back in 2012 when we first started working on they actually came out of a consensus conference that we hosted back in 2012 where they asked us to simplify and make things easier for patients to understand. So I would say absolutely your comment is correct, that was meant to increase transparency for patients in terms of those key metrics that we had for waitlist, speed to transplant, waitlist mortality, and post-transplant outcomes. I would say, too, the SRTR is completely open to the discussion of if we should fix that, if we should replace that with something like overall survival from listing. That is something that we're engaging with patients now. Is that something they would rather see than the breakdown of each of the three? But we're completely open to that. But it was born out of a recommendation to make the data more accessible.
So with that, thank you, John. Yeah. Appreciate it. I'm going to go on to the next topic. Again, these are just four meant to push discussion. There's other topics we could talk about also. But one of the other big things, we already touched on this a little bit, is what we call rescue pathways. And I say rescue because the effort is to rescue an organ that's at risk for non-use or non-utilization. It's not designed the way this isn't the way it was designed, but it's important. So these aren't, people say expedited. I don't like that term as much because that makes it seem like it's doing the right thing quickly. We see this as a response to an imperfect system. So we'd like to understand better, and this is also some feedback we've gotten from ASTS and others. What's the problem? What's driving this? What are we trying to accomplish with this? And again, always putting the patient in the middle and always trying to make sure that we're still successful and still equitable. Those are always our balancing metrics. So why are these organs not being used? We understand and agree across all organs that a cold ischemia time drives this as one major driver, and that data is pretty clear. But there's other things too, and sometimes they make sense and sometimes they don't. We talked yesterday about biopsy stuff. We know that Europe doesn't biopsy as much. So what things about biopsy would impact, what things about pump numbers, what are the things in other thoracic organs that would make a difference, what should we be looking at? But cold ischemia time, I think, is a starting point. And then what do we want to test? So if we are doing a variance and it's a pilot, a small PDSA that's meant to be iterative, ex ante, what are the things that we're trying to test? So what can we change as a result to make an improvement so that we understand the data, understand the next iteration, and then eventually get to a point where we have a policy that makes sense and has been tested. So example of this that we came up with, a rescue placement pathway that drastically reduced cold ischemia time, has been done with certain OPO transplant center collaborations, right? It takes two to tango. That we can potentially drastically increase organ usage, and everyone can agree that's fair and equitable to use more organs and take more people off the wait list. And then how do we know this was an improvement? So we have to not just go and do a variance, but design this, and with John and our SRTR folks help have a dashboard and have predetermined metrics that we could follow, such as increasing organ usage. So some suggestions that we've come up with, this is just, again, for discussion. I'm interested to hear your thoughts. So in kidneys, cold time is a common trigger for kidneys not to be used, so post-cross cold time. And so we know from talking to OPOs that have done this successfully that they use different factors, but as you march out in cold time, the risk of non-use for the kidney goes up, and so maybe that you could trigger different rescue pathways like in a bullseye as you go across and follow that in a predictable way. We also could look at, as I mentioned elsewhere, different centers have different acceptance, and to build that into the equation. So these are things that we're looking at in terms of doing this. So I'd like to open up for questions again, to have a good discussion about what you think would be a reasonable way to go about looking at rescue pathways, so that with the intention of designing future policy that better meets our needs, especially with medically complex organs. And I'm going to be totally surprised if there's no questions. It has to get questions.
Stuart Kneckley from Duke again. As I think has already been suggested, there is different behavior of different centers with regard to acceptance rates.
Right.
The fact of the matter is we have all that data available to us, and that is part of building a better information platform. We know exactly the behavior of every transplant surgeon and every transplant program in the United States as far as their acceptance criteria. So you should be able to say that if this program or this surgeon has a less than 50% chance of accepting this organ, we should bypass them and go on to somebody who has at least a greater than 50% chance. Otherwise, we're introducing the exceptionally high clutter in the system that's already been mentioned by our colleague from the OPO. So a better information platform that incorporates that data can design such a system to be considerably more efficient, so that instead of spending 20 hours allocating a kidney, you spend a few minutes.
Don't disagree, obviously, and as you know, keeping track of individual, because the surgeons are very different at different programs, so the offer filters as described, at least for kidneys, would take into account program. So if they never took a kidney or a kidney over 500 miles or, et cetera, then that would be the filter. But that doesn't take into consideration the level of granularity that you're talking about with individual surgeons, which although I think it's discoverable, it's not there quite yet in terms, that's a more complicated information system, but one we could look towards.
That system has been built, and I won't go into who's built it, but that already exists. So we could use that kind of a system to help us allocate more efficiently.
So Stuart, what you're saying, is on the physician side of it, that really appeals to me personally, because we see that a lot. And I wanted to use the opportunity here to point out the Expeditious Task Force has a website where folks can, if you don't bring it up here, you can go there and submit ideas. So the only thing I'd ask with that concept is we want to be careful that what you don't create is an environment where you get sort of benefits by being at certain centers and get bypassed at other centers. And there probably will be no perfect system that's able to balance those two. But in designing that approach to a rescue pathway, I think we have to make sure that patients that might be at smaller centers, more rural centers, don't have access to a center like Duke or something, they can still get access from these rescue pathways. And that's kind of where we're thinking about this. So just add that to the list of how you think about it.
Completely valid point. I agree that you can't be totally shut out of that allocation system because you have a history of never accepting such a kidney. But as has been mentioned already by our OPO colleague, that has been used as a pretext for being included on the allocation list to the detriment of kidneys in patients.
Yep, agree.
Hi, Deb Sudian. My question is actually more on the implementation side of the ideas that you have suggested. How do we get the OPTN to create the IT needed to implement the variances and keep track of them so that we actually have the data at the end of the variance, given the changes that are ongoing and the long time it takes currently to get new policies into our IT system for the allocation changes?
An excellent question that I wonder about also. I don't have a good answer because of, as you know, we have been, at least up front, leaning away from, not because they're not important, but things require a large IT lift because we don't know, the contract is under negotiation and the modernization initiative is ongoing. So I think that's an important question, but I don't know what the answer to that. Have you ever?
I think that's like what did I say, the elephant in the room, that's the thing you say. But that'll depend on the contractor that's given the IT support version of the contract and how much resources are dedicated to that project, I would say. It's certainly, the notion of, and the OPTN, I would say probably we don't have authority over that. But the policy development aspect of it, I think you've hit on something that falls into this task force. And so before 2014, policy development was, went at a glacial pace, right? And then there was this initiative to make every policy from, implementation, from approval to implementation, et cetera, 12 months. And that was sort of a one-size-fits-all. And certainly part of the efficiency or making the OPTN more efficient, it could be something like continuous distribution. That might take longer, but something like the EGFR policy, clearly doesn't take the full 12 months either, right? So right-sizing the time devoted to both development and implementation to the policy needs, I think, is something that we would definitely be looking at.
So just a clarifying question then. Are you suggesting any of these variances would not go into effect until after the modernization is completed?
No, we would say that the variances would be designed to be small, short-term pilots, so none of them meant to be permanent. So they'd have a predetermined length measured in months, and that would be enough to have enough numbers to make sense of the data, and then there would be an iterative process. So while we're looking at what the factors are, and to an earlier question, the definition of medically complex or hard to replace organs, we're also at the same time in parallel trying things. One of the things to be out of a rescue pathway. So, but when we had some data and we could agree as a community that this was a pathway that worked, then that would go out for the traditional committee approach, which would be full public comment committee, and then go into policy with IT implementation.
So I think that what your question did was give us a great chance to maybe focus on this. My hope is that more of these PDSAs fail than succeed, right? If we do PDSAs that fail, we learn from our failure, number one, and it also means people are engaged and we're trying new ideas. At the end of the day, should one of these projects that we undertake, everybody agrees, hey, this looks like it has value, then that would be, a PDSA, to turn a PDSA into a true policy is going to take more than just, hey, this worked, right? There's a lot more that goes into making a policy than just a quick experiment. A successful PDSA would be turned over to the committees of jurisdiction, and then depending on the complexity, that could take a year, it could take 6 months. I think that would be right-sized to the project being done.
Yeah, because I think as a legitimate question, I fear that we're not going around the policy. It's simply using a way to pilot small changes and understand before you ever got to policy.
Sure. I guess the follow-up to that, though, is still, do we have the resources to do the data analytics and gather the data and analyze it without, in this time when so many things are changing? Do we have that?
It's a legitimate question. My answer, again, derivative from our analytic colleagues, John included here, is yes. We wouldn't do a pilot that we weren't able to have the data, didn't have predetermined metrics, and didn't have balancing safety metrics like equity and outcome. So absolutely, it's an important question. I think the answer would be that yes.
Sanjeev Anand from, a transplant nephrologist from Intermountain Medical Center. So coming to the cold ischemia time, if centers are not accepting kidneys, which is maybe 700 miles across the center, there are very nuances to why they are not accepting. One of the challenges is logistical challenge, right? So this happened the other day. The kidney is going to land at 10:30 and the cargo gets closed. So you can't put a hand on the kidney till 6 a.m. when the cargo bay opens. And that's how kidneys are treated right now. So I don't know if the task force is looking at partnership with any of these courier companies, FedEx, UPS, whatever it is, to expedite logistically and get these organs. I mean, there are centers willing to accept these organs, but the challenge is logistics to get them in the right time so that the cold ischemia time can be minimized.
Thank you for the comment. Couldn't agree more. We're actively looking, as you imagine, and as you point out, to looking at other barriers. And so those might be regulations, that might be partnering with companies like UPS or FedEx, looking at pump technologies. There's lots of other logistical things that feed into the ability to limit cold time. It's not, right, it's not just the fear of bad outcomes. And so there's lots of other pieces to that that are also an important thing we're looking at.
I don't, this is a little bit outside the task force because the current contractor is working on this as well, but apparently, and I'm not, I don't know federal regulations, but the FAA, I think it's called the FAA Authorization Act, or I'm not sure the proper naming of it, but it has to be reauthorized, I don't know, every sequence of 3 or 5 years. I'm not really sure what it was. But it turns out what you're getting at there, though, is how policies that make sense in one context make no sense in another, right? So you talk to most people in the OPO world who think about this, the very fact that you're putting an organ into cargo versus carrying it in the cabin probably adds 4 to 6 hours of cold ischemic time for the reasons that you've just identified, right? But then have you ever asked the question like, why is it in the cargo, right? It used to fly in the cabin. I remember when I was growing up, there was always that, the cooler getting rushed into the OR in the videos, right? And it just happened after 9/11. And when we just started asking questions, nobody had an answer as to why, right? This is just one of those things that just started happening. Nobody asked the question, and then all of a sudden we were just doing it. And it's not something that Alden and I have been directly involved in, but there probably is no reason it can't go back into the cabin, right? And hopefully, maybe that will get through, and that will be a quick fix.
Thank you. Bekir Temri over University of Arizona. One of the approaches hard to place very high risk non-used kidneys, actually defining them early and using a different pathway and allowing actually these kidneys only be used by the local, however you define it, and just send this kidney to centers, run the list, but allow the centers officially place these kidneys whoever they want to place, implant these kidneys. So like behind the scene, we're doing this anyway. It's just kind of like giving different reason is this patient is either size mismatch or patient sick, or you're using different reasons, bypassing the certain patients and going down to whichever suitable. You're making all the calculation behind. Just allowing the centers actually just to use these high-risk kidneys, whoever they want to use with the minimal cold ischemia time, kind of make things much easier. And that's, I think, certain kidneys should be allocated differently with a different algorithm.
We absolutely agree, and I would just counter with a counterfactual is that you have to make sure that patients have transparency and it's equitable. So that's what's not always happening. So we can all agree that a kidney that's not used benefits nobody. And we know that certain OPOs with transplant centers are doing that, but sometimes other transplant centers are out of that relationship, and some patients are being bypassed without having a way to look at it. So we want to design a system that does the things that you say, but also maintains equity, follows the final rule, right, and is transparent.
I think that this is more allowable for hard-to-place kidneys. It's kind of like we need to accept that this is a fact. As a community, actually, it's just we know that 60 to 80% of those kidneys are going to be discarded. And the equity is, I'm not sure how important at that point is certain portion of the kidneys.
Totally agree. So when we came up that 60,000 I was talking about, again, this doesn't require new donors and new technologies, although we know that and hope that they're coming, but we feel like if we used all the organs that are available to us that are actually transplantable, understanding that they're not all transplantable, that we could probably get to 60,000 right now if we had enough OR time, had an efficient process, we're able to allocate these organs. Yes, thank you for that comment.
So that's a great, another thing that we can pitch to ask you guys to work on, right? So what you were talking about is center allocation. Currently noted doesn't let you do center allocation, right? You have to allocate to patients. And then the question would be, and I think there's ways to do this, how do you accomplish both of those goals, right? So when you're thinking of rescue pathways and you want to make suggestions, the concept of getting organs rapidly to centers that'll use them, we all agree on. And then how do you do that within the construct that we have to still abide by, which says that organs are allocated to patients and not centers?
Tom McCune from Centera Norfolk General. Piggybacking on my comment, my colleague from Wisconsin at Intermountain, if we're going to look at how to minimize the cold ischemia time at the center who's taking the kidney based on a designated OR, can we also look at the donor retrieval time that correlates to the airlines so that we don't have a kidney that gets taken out at 2 a.m. and is going to sit there till the 7 a.m. flight?
Also a good discussion, suggestion, thank you.
Hi, Pooja again. I just have a quick comment. So we get our organ offer acceptance ratios every 6 months, and we also in between get that one-sided CUSM week by week that some of us review, not all of us review. We are so focused on the highly aggressive centers, I think we cannot leave our other centers behind. And changing the mindset of a center takes time and effort. Currently, there's no mandate that if you're hitting that infamous red line once in a while, that you should sit down, pause, review that week what happened. And many a times it's not just a surgical preference, it could be your wait list is not ready. And you had to say no to a patient because the organ was great, but the patient wasn't ready. I think we have to trickle that message down from UNOS that you need to do something internally, like an organ offer acceptance meeting or turn down meeting on a monthly basis if you're hitting that red line below a certain organ offer ratio, to build that culture into those programs to get to a yes. Thank you.
Couldn't agree more. And part of our effort, you see my next slide here, is how we can teach best practices, because so much of this is like learning how to do things and getting other programs comfortable with new techniques or different ways to manage it.
Your comment, though, made me think of something. So it is very true that at the end of the chain, it is a surgeon that makes the decision to accept and to transplant a kidney or an organ, right? But I think we have to think of what's the system that gets that organ to that individual. So as we're talking about this, it's true at the end of the line there's a surgeon who has to stay up at night and put the kidney in, but there's a whole system that moves that organ through time and space and make that system support that activity, not just focus on that activity and say, we have to fix this, we have to look at that. I think that's a change in the mindset, but I think we all have to take responsibility for the system at large. And what are we all doing? So the comment about donor hospitals I thought was a really good one, because that is actually where the chain starts, and that's actually where the OPTN doesn't have any ability to really regulate at the moment, but these conversations, you could imagine conversations with CMS could focus on that, right? And that would be something that we could probably work on.
But point well taken. It's a culture thing and a comfort level, and there are things that we can do to, as Rich said, to support this system. Like maybe another thing that's come up is maybe not to push out offers from the OPO, as many offers, and not to push out offers in the middle of the night for donors and aren't going in till later. You know, so make this a more of a livable system for programs that are getting a lot of offers too. We're actually doing great, nice discussion. So another topic I was going to turn to is community forum planning. So much of this is communication, so much of this is getting folks on board. So some things that we thought, this is also important. This is something that we not always done perfectly. So how can we bring different stakeholders together to solve a problem? And that's, again, sometimes has been pointed out, those are the people that are obviously in our ecosystem, and sometimes those are people outside of it. Engaging the community. So there has been this, in this time of uncertainty, sometimes the community has had distrust, and so the ways to manage that is to have communication and bring them into the discussion, donor families, the patients. Have enough time, because these are complex topics, even for us who've lived this life for decades. We have to think through how to message this. Having working sessions, not just presentations, using different techniques for different audiences, and try to ask, what efficiency and utilization problems might be best or most easily solved through a forum type event. An example of this, I think a good one is NRP holds a lot of promise, has some complexities, there's some ethical issues depending how you do it. But no doubt it makes more donors have organs that are transplantable. So having a forum that takes the best practices and talks through this would be something that obviously makes sense. And so use the communication style or use different fora to push out best practices or get people involved is something we also think is super important. So something that we've been thinking about is a separate patient-focused event to all the comments before to get patients' feedback and to understand what they're interested in. We know, for example, as I mentioned before, that patients who have some savvy about this and have access to different centers, that the most important thing for them is to have agency and have access to organs. Something that we think is super important for reasons that have been mentioned is getting C-suites involved. It can't be that we get to 60,000 organs without a lot of hospital resources. So already, with Diane's help, we're hosting some C-suite events where we're getting folks together who have been able to do this at programs and those who are interested, so that, again, making the messaging outside of our traditional ecosystem to those who control some of the levers that will be necessary for our success. I talked about going to CMS and the involvement, at least in that discussion with some of the insurance companies, but aligning metrics and incentives to invite payers to be part of this. Thinking about ways that you could pay for donor runs when no organ is taken back, and to think about ways and to pay for all this technology that is more important. It's important all across, but more important to make sure that medically complex donors work, and also more important as we more broadly ship organs to get equity gains, then things like ex vivo perfusion become important. And as I mentioned, to disseminate effective practices, different donor testing, maybe some barriers there, communication. We've had a lot of discussions about virtual cross-matching and making programs comfortable at doing more virtual cross-matching in a safe way, standardizing biopsy reads, just on and on. There's lots of donor management. There's such exciting things happening in donor centers with the goal of having the best organs come out of donors and the most organs per donor. That's like a science that chapter is being written now. So how do we make sure that donor centers, which is a part of the NASEM report, get the resources and they need to be able to continue to innovate. So I also wanted to open up a discussion, and we're running out of time, but let's have a quick discussion about what you think, what are the fora that we could set up, what are the ways in which we could better communicate this across our community so that we can be successful.
I completely agree with your agenda there, and one practical way to get the C-suite involved is to link organ donation to the star ratings of hospitals. We have to use indirect methods like that so that we're not accused of serving ourselves by increasing organ donation, but the C-suite does pay attention to the star ratings because that is linked to their reimbursement. And I think it's obvious that the behavior of C-suite is critical for this. One of the hospitals in our DSA has 2 to 4 times the organ donation rate. We know that even transplant centers historically have a poor organ donation rate. It's some of these hospitals that have made organ donation a priority for their ICU staff and nurses, and when they focus on it, it's effective.
Excellent discussion. I couldn't agree more. We also thought about a nationwide messaging if it could capture the attention of the secretary to say that, because transplant has great optics. That's one of the things that we obviously save lives, and people widely agree on that. And so have it come up to the national, a national level that this is something that we're doing now. I think we have time for one more question. I'm sorry to run out of time. Thanks for the discussion.
Ernest Davis. So I'm bringing a lot of hats to this answer. As a C-suite executive, I can say we rarely heard from transplant until they needed something. And as a recipient, I can say, when are we going to stop making this transactional? That when we have something to say, that's when we communicate. It needs to be more relational not just with patients, but across the line, because a lot of times transplant works over here until we need to go and talk to the FAA, which happened when I was on the board. We work over here until we need to go and say, patient needs to be educated. Once the patient is educated, we're leaving them and do what we do over here until we need to give them something else. So just trying to make things a little bit more relational as opposed to transactional across the board, and stop focusing on events, but on how to engage these separate stakeholders in a meaningful and long-term enduring way.
Such a great comment. Thank you. Yeah, and we've heard that also from when we brought in folks in the leadership of some of these programs that have done that well. It's always as you describe. It's you develop the relation and make that a relational discussion, and you develop that and get them on board, involve C-suites in the success and patient level things. And so we hear that loud and clear. So I'm sorry I ran out of time, so we're not going to go to the fourth one, but I really appreciate all of the discussion. We invite your comments to these things and others. Trying to do things differently. We're open to suggestion. We want to represent the whole ecosystem and make some change. Thank you.